Go. Good
Namaskar.
evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Prematurity, organized by UPNIGF Society. So it's my privilege to introduce Dr. Amrita Sarkari Jaipurad ma'am. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. A very good evening to all the respected faculty, seniors, and dear delegates. It's an honor for me to introduce you to the very first webinar of the UPNIGF. In the capacity of the Secretary UPNIGF, I extend a hearty welcome to all of you. We are all very lucky to have mentors and guides as Dr. Sharda Jain ma'am, Dr. Sadhna Gupta, and Dr. Ragini Agrawal. I'm sure under their guidance and leadership, we are going to achieve new heights. The theme of today's webinar is prematurity, and we are doing it keeping in mind the World Prematurity Day, which is on 17th November 2025. Before we move on to the sessions, let's invoke Goddess Saraswati and seek her blessings. Leadership is all about moving forwards together with everyone. It is hand-holding. This is the quality of our President, Dr. Hema Shobhane. With immense pleasure and pride, I invite Dr. Hema Shobhane for the welcome address. She is the President UPNIGF and Head of the Department Gynae and Obs at MLB Medical College, Jhansi. Over to you, Hema ma'am.
Thanks, Dr. Amrita Jaipuriya, Secretary NIGF, very dynamic and sincere worker for NIGF. And thanks for inviting me. Very good evening, everyone. It is a great honor and all NIGF members in NIGF webinar series. NIGF UP chapter team working under guiding force of respected Dr. Sadhna Gupta Madam, Chief Advisor UP chapter NIGF, to fulfill the dreams of respected Dr. Sharda Jain Madam, Chief Patron, respected Chief Patron NIGF, and respected Dr. Ragini Agrawal Madam, President NIGF.
Are you able to hear?
No, ma'am. I think the network is not working.
Network problem.
So, at the outset, I would like to invite Sharda Jain Madam, who is the patron of NIGF, for her blessings. She is the mentor of many of us, a teacher of teachers. Over to you, Sharda ma'am.
I think my great good afternoon to each and everybody. Prematurity is a very, very important topic, and for we gynecologists, because prematurity as such give rise to 45 to 40% of the neonatal deaths. And I think, gynecologists have to आपको कमर कसनी है for prematurity prevention, because prematurity now it is possible that you can curtail it to a large extent. And I think our journey starts when each one of us are work on the prevention of prematurity, because there are many states where the neonatal death rate has come down to 1, 2 and less than 5. And I think in case prematurity remains in the magnitude it is, I think all of us have to make a contribution that we do not have preterm births. So I think this, with this particular thing, I give blessings to the people who are organizing this particular show, that all gynecologists must get stimulated as far as their work is concerned. Thank you very much.
Thank you, madam, for your wonderful input. And now I invite our president, central president, Dr. Ragini Agrawal, for her blessings and words of encouragement. Over to you, Ragini, ma'am.
Thank you, Amrita. Very good evening to one and all, respected senior and friends. Heartily congratulations to the UPI NIGF for this webinar on a very, very important topic of the prematurity. We all know prematurity is one of the major reasons of mortality and the morbidity in the neonates. Not only this, it puts a lot of economic pressure on the society, on the parents, and the emotional trauma. Not only this, the kids who are recovered from the prematurity, many a time although they are salvaged, but they have lots of problems in terms of the neurocognitive behavior and everything. Still, Western bird is not also able to conquer the prematurity, but steps what we can take, we should do one by one. And the most important thing, if we have a premature baby, please try to refer in utero to the centers who can take the proper care of that very, very premature baby. And with this word, as the great speakers are there, my own teacher, Dr. Manju Verma is there, the first president of NIGF, and the future ICOG chair, Dr. Sadhana Gupta is there, and so many IC professors. Jaya is there, and everyone who has joined today is going to get benefited. And if they can make a little difference in their practice today, take one tip. I think Hema and Amrita and Bharti, or all, whatever you want to do, it is fulfilled. Thank you so much. Over to you for the academic session.
Thank you, Ragini, ma'am. And now I invite Dr. Bharti Maheshwari, who is our Vice President, for her welcome for Dr. Sudha Sharma.
First of all, good evening to everyone and namaskar. And I would like to congratulate Dr. Amrita Sarkari, in fact, Secretary of UP, NIGF UP State, and that she has started this webinar on a very important topic. That is none other than on the prematurity. And as Dr. Shada Zain and Dr. Ragini Agrawal, madam, has already told about the importance of this topic. And now I would like to introduce Secretary of NIGF, and that is Dr. Sudha Sharma, madam. That we all know that I know her personally also, and we all know she is such an academic person. She's a former professor of the Department of OBGY, GMG Jammu, President-elect IMS 202526, and has lots of credit for their publications, as well as editor-in-chief in Journal of Midlife Health, as well as in the Journal of CEPOG, and faculty member consistent documented in IMS, and lots of academic credit. So over to Dr. Sudha Sharma, Secretary of NIGF, for a few words.
Thank you so much, Dr. Bharti, for that kind introduction. A very good evening, everyone. I see here so many respected teachers. I must say, like Dr. Sharda Jain ma'am, somebody said teacher of teachers. Very true. Even Dr. Sadhana, Dr. Ragini, Dr. Hema, and so many of you are there. A very good evening to all of you. Heartiest congratulations, Dr. Amrita and team NIGF UP for organizing this webinar, and the topic is so very important. I think Dr. Sharda and Dr. Ragini have highlighted it, and you have invited a galaxy of speakers, I must say. So without wasting any time, all the very best for this, and we are here to listen to our eminent speakers. Thank you so much.
Thank you, ma'am. And now we move on to our academic sessions. And for the first session, I hand over the platform to Dr. Shikha Singh from Agra. Over to you, Dr. Shikha Singh.
Good evening, everyone. A warm welcome to all the attendees. And in the UP and IGF banner, we are having a webinar, and the credit goes mainly to Dr. Amrita and all the members of UP and IGF. It is a move forward in the scientific field. And for the first session of today, I'd like to invite our chairpersons. First of all, we'll be inviting our chairperson, Dr. Jaya Chaturvedi. She is presently Dean Academics and Professor and Head Obs and Gynae, AIMS Rishikesh. She is a MBBS and MS alumni of GR Medical College, Gwalior, Madhya Pradesh. Formerly, she was Professor and Head AIMS Dehradun. She is a recipient of various awards, including Jagdeshwari Mishra National Award and State Felicitation. She has actively participated in various projects under RDI in MCH care, sexual and reproductive health funded by GOI, WHO, and numerous other agencies. She has published and presented around 75 papers in various journals and conferences. She's been Vice President, Uttaranchal Chapter of Obs and Gynae since 2002 and Foxy Dehradun branch since 1999. She's examiner of both MBBS and MS of various universities and has been expert in UPSC and ESIS. Our next chairperson for this first session, Dr. Sudha Sharma. She's a former professor, PG Department of Obs and Gynae, GMC
Thank
Jammu.
you, Doctor.
She's president.
Introduction has already been done. Thank you so much.
Already been done. And
Yeah.
as chairperson of this session, we again invite Dr. Sudha Sharma ma'am.
Thank you so
The
much.
third chairperson of our session is Dr. Sangeeta Gupta. She is Professor, ESI Medical College Hospital, Noida. She is ex-HOD, ESI PGI, Basedarapur, Delhi, and founder secretary of DGF and presently vice president of DGF. She is founder member of NIGF, convener of NIGF Kanun Ki Pathshala, films on examination of a rape victim in 2006, examination of sexually assaulted victim in 23, and examination of victim of CSA in 24. She is recipient of APJ Abdul Kalam Excellence Award in 15. She was first and third Oration Award of DGF in 2012 and 21. Her field of interest include eliminating preventable maternal mortality. So numerous accolades to Dr. Sangeeta Gupta's CV. And these are the chairpersons of our first session. And I would like to invite Dr. Sudha Sharma to introduce our esteemed speaker, Dr. Manju Verma, ma'am.
Ma'am, you're muted.
Can you hear me? So it's my pleasure and proud privilege to introduce someone who is a true academician, Dr. Manju Verma, retired professor and head, past president UP chapter of OBGYN Gynae, certificate of honor in medicine, Dr. Shiv Narayan Gold Medal, BC Pant Gold Medal, Lakshmi Ratnan Pandey Silver Medal, Chancellor Bronze Medal. My God, madam, you have received so many accolades. President Gold Medal, then Prashansa Patra and Silver Medal, 86.
बहुत बार पढ़ा जा चुका है, सुधा बंद कर दो बहुत
12 gold medals. Oh my God. The list is on and on and on, my God. So over to you, Dr. Manju Verma, ma'am. Please, the
Thank
floor
you.
is all yours. And we are, so lucky to have you as a speaker. So just waiting to listen to your, pearls of wisdom.
Thank you, Dr. Sudha, for introducing me. And first of all, I would definitely like to thank and extend my love to Amrita, Ragini, Sadhna, and Shobna, and Bharti. All of them, we are so closely associated with each other that we, like to meet as many times as possible. And NIGF has given another platform for us to meet again and again. And I would like to congratulate the UP State and IGF because this is the first they've started a webinar on various themes, which will be very, very useful for the society as well as the nation. as well as the health of the fetus and the mother are concerned. So I am going to share the literature available on chorioamnionitis. Jaya, I forgot your name, so I am adding your name. Yeah.
Ma'am, I am your student.
So, so this is basically, I would like to share the literature on the chorioamnionitis. And as we all know, the definition goes in that there is an infection resulting in inflammation of the any combination of fetal membranes, right? Chorion and amnion. This was the definition which was given in the past. ACOG has now added the amniotic fluid infection, placenta, umbilical cord, and even the fetus in the same head as chorioamnionitis. So all these things, the whole component of the pregnant uterus is being included as the chorioamnionitis. Now, for the purpose of description, this chorioamnionitis has been divided into two, that is clinical chorioamnionitis and histological. This was very, very important as far as because the end result of both the type is different and has to be taken care of differently. So the clinical chorioamnionitis can again be divided into acute and subclinical. The acute is basically the mother is symptomatic, so you can find out very easily and can be diagnosed. And this results in the emergency symptoms in the form of adult RDS and CV, cardiovascular instability. Then the basic organism which are involved with it is the group B, Streptococci, E. coli, and Streptococcus viridans. The subclinical is basically associated with the preterm labor, and most of the time it may be asymptomatic, but it is very hazardous to the neonate because it is going to result in chronic lung disease as well as preventricular leukomalacia in the newborn. So, and the basic organism involved in this is basically our urea, plasma, mycoplasma, and Gardnerella. Coming on to the histological type, this is 3 times commoner than the clinical chorioamnionitis, but it cannot be confirmed unless there is a histology taken after the baby is being delivered of the membranes and placenta. So this is basically a ascending infection, and it is difficult to identify, and organisms are difficult to culture as well. Now, coming on to the definition of clinical chorioamnionitis, this is fever is the constant symptom. In addition to the fever, there should be at least 2 of the following parameters. That is, the maternal leukocytosis should be more than 15,000 with fundal tenderness, and maternal tachycardia. It is given here as 100, but most of the place literature it is 120 beats per minute. Fetal tachycardia, purulent amniotic fluid discharge, and foul-smelling amniotic fluid. Now, this acute chorioamnionitis, basically, I've already said, and the organism has already been discussed. But the most important thing is that the 25% of infants, if they weigh more than less than 1,500 grams, are bacteremic, with one of the organism which is there in the mother to be present at the birth of the fetus. The definition of the histological chorioamnionitis is that is basically an invasion of neutrophil which comes from the mother, which can invade the choriodocidal space, the fetal membrane, placenta, amniotic fluid, umbilical cord, and even the fetus. Now, this is again a representation of the same thing, that from the I don't have a marker, but then it is from the blood vessel, the neutrophils go into the chorion, then into the amnion, and may go even up to the amniotic fluid. Now, why it is important to learn about this clinical entity is that the impact which can be seen on the epidemiology. Now, this overall incidence has been quoted in certain studies as 3.9%. The term deliveries is contributing to 1 to 5%. Preterm deliveries contributing to 40 to 70%, and extreme preterm, that is less than 24 weeks, up to 94%. At term deliveries, the most important clinical factor that is important is the PROM. And if the PRM is considered as a whole, it contributes to about 7%. It can occur, but if the membrane rupture is more than 24 hours, then it may go even up to the incidence of 40%. Now, histological chorioamnionitis ranges from 50 to 70% in very low births to 10 to 15% in term infants. The preterm labor have a high incidence of histological chorioamnionitis, that is 30%, but maximum is with there is PPROM. 80% may chorioamnionitis can occur. Now, coming on to the etiology, the basic four mechanisms are involved, and the most important, the primary mechanism, is the ascending migration from the cervicovaginal flora. The next can be hematogenous, which can come from because the maternal bacteremia or septicemia. Then direct invasion can also be introduced into the amniotic cavity when we are doing amniocentesis or any other intraamniotic procedures which are being carried out. The fourth and the least common is the direct one, that is descending from the peritoneal cavity if the pus or the infection is there through fallopian tube to coming on to the this is just a diagrammatic representation of what I've already said. Then coming on to the pathophysiology, this the chorioamnionitis is the ascending migration of cervical flora as being well established. The cervicovaginal flora, when it is introduced into the conceptus, the amniotic, the infection can result in the two things which can result, that the labor can be initiated or there can be rupture of membrane, or there can be immune system which can be activated in the mother, or if the neutrophil, the fetal immune response also is being excited. So this is just a diagrammatic representation that when the infection occur in the mother with virus, bacteria, or parasite, the basic pathology that occurs is in the placenta first. So there is macrophages invasion as well as CD8-4 cells that are there. Plasma cells are producing antibodies, and neutrophils are there being infiltrated into the placenta and the membrane. And this is basically resulted in an inflammation and injury to the placenta. While the fetus, basically it is the brain which is being affected. And there is the basic pathology is the oligodendrocytes there's a death of dendrocytes, and then there's an activated microglia and neuronal death of the axon as such, or of the axon may be lost. So this all will result in the changes which can occur later on in the clinical life of a neonate. Now, coming on to the microbiology, the various viruses, if I enumerate, I'll take 5 minutes. So this is the list of viruses, parasite, and basically the bacteria which are responsible for infection in chorioamnionitis. This is a pie diagram being taken from so many studies, and they have given the percentage involvement or percentage exhibition of the chorioamnionitis. And coming on to summarizing these two figures, it is as been shown, it is polymicrobial, which includes both anaerobes and anaerobes, and most common ones are basically the genital mycoplasmas like ureaplasma, or mycoplasma. It can be Gardnerella, maybe bacterioids, or maybe enteric negative rods like E. coli, group B, streptococci, and listeria. Now, this slide shows you exactly what is the incidence difference between, which is the most common. So, the culture proven chorio is uroplasma is the maximum, contributing to 47%, mycoplasma to 30%. So, the mycoplasmas are most involved organism as far as the infection is concerned. The other organisms can be Gardnerella 25%, Bacteria 30%, GBS 15%, and E. coli 8%. Anaerobes is more in preterm than in term pregnancies. Now, it is not only the infection, it is the host defense mechanism which is also responsible, because once infection occurs, the host mechanism, the defense mechanism can take part. If it is strong, it will not let the infection occur. But if it is weak, then the chances of infection becomes much more. And to enumerate the mechanisms are basically it is the cervical mucus plug, the fetal membranes, and they act as a barrier function they have. And then some studies have proved to that the membranes have got an antimicrobial activity. They also modulate the immune response, and vaginal, the peroxide producing lactobacillus is also responsible for the curbing of the bacteria which are there. This is again a diagrammatic representation of the infection that can take place. Now, coming on to the clinical part, that is the risk factors. The risk factors are basically the prolonged rupture of membrane, more than 18 hours, most significant risk factors, and in both term and preterm. There is the chances becomes much more when there is a prolonged labor or there is a preterm labor. With preterm, PROM and PPROM both are very, very important as a risk factor. Multiple digital examination, especially done if the membranes have already ruptured. Use of internal uterine and fetal monitors, intra-amniotic the procedures that are being done, and the basic organism that is involved in this procedure is the group B streptococci, or even the STIs are responsible in cases of genital tract pathogens which may be present during labor. Primary is much more prone to have chorioamnionitis. If the meconium staining is there of the amniotic fluid, the chances becomes much more. The short cervix, incompetent cervix and short cervix is also supposed to be important causes, with epidural anesthesia and substance abuse in the form of tobacco and alcohol use. Now, coming on to the clinical chorioamnionitis, the most important risk factors are the GBS colonization or bacteriuria. Of course, primary parity, then internal monitoring devices, meconium staining, serial vaginal examination, duration of active labor, if it is more, and duration of rupture of membrane. If there is a history of chorio in the prior pregnancy, and if we do investigation, we find that the single nucleotide PMNS in immunoregulatory genes is present, and then the levels of interleukin 10 and interleukin 16 are also very, very important as far as the risk factors are concerned. Now, coming on to the clinical picture and the sign and symptoms which can occur in cases of chorioamnionitis, the most important one is the maternal fever. And this fever has to be, more than, I will come into detail of that. Then it is diaphoresis or excessive sweating, hypotension that can occur in the mother with uterine fundal tenderness, the significant maternal tachycardia that is more than 120 beats per minute, fetal tachycardia more than 60 to 180, purulent foul smelling amniotic fluid or vaginal discharge with maternal leukocytosis. So, primary manifestation that are there, just to come to shorten what has been given, is the uterine fundal tenderness, fever, and discharge, which is foul smelling, then maternal tachycardia, fetal tachycardia, and reduced fetal heart rate variability. Now, when we come on to the diagnosis of chorioamnionitis, there are three categories which have been described, and they are isolated maternal fever. They can be suspected chorioamnionitis or confirmed chorioamnionitis. Then isolated maternal fever. Now, this must be maybe the only presenting symptom. So when will we call it fever in chorioamnionitis? When the temperature is more than 39 degrees Celsius, that means 102.2 degree once. Or there may be a temperature between 100.4 to 102 on two occasions 30 minutes apart. So we have to take the temperature twice if it is 100 after 30 minutes. And if the fever is only there, then the chances are that we have to rule out, because this again is a diagnosis of exclusion. So urine analysis has to be done with blood culture, and then sputum testing, and other causes of fever have to be excluded out. And if no other source is found, then then recommendation is that patient should be taken as a case of chorioamnionitis. Once it is isolated fever, now it is a suspected intraamniotic infections, and this is fever. Along with fever, there should be one of the following. That means all the parameters which I've already discussed: fetal tachycardia of more than 160 beats per minute for more than 10 minutes, or maternal leukocytosis, which is more than 15,000 per meter per millimeter cube. Then the purulent discharge on examination. So any 1+ fever if there, then one has to suspect chorioamnionitis. The confirmed chorioamnionitis is basically when positive amniotic fluid test. That means you do a culture, but takes a very long time, so this cannot be taken much. But this is the gold standard. And when we do the amniotic examination, we also find out the glucose levels in the amniotic fluid and WBC count. The histopathology, of course, is done later on when the baby is delivered. So diagnostic methods which are available to us if there is no symptom, that means only fever is there, and there is not even fever, it is only the premature labor with PROM. So then the examination of amniotic fluid should be done. Maternal GBS screening should be done. Maternal blood studies in the form of CBCN has to be done. And then maternal blood studies and maternal urine examination has to be done for urinary tract infection. So once mother has fever and has suspected chorioamnionitis, that the tests which should be done are WBC count, C-reactive protein in mother, then alpha-1 proteinase inhibitor complex measurement, and serum interleukin 6 or ferritin levels to confirm. I'll come to the levels later on. Then if the amniotic fluid is to be evaluated now, and this is the bacterial culture has to be done, leukocyte count has to be done, gram staining, pH of the amniotic fluid, glucose concentration in the amniotic fluid, leukocyte esterase activity, endotoxin, lactoferrin activity, and cytokines levels in especially the interleukin 6, PCR for microorganisms, fetal fibronectin, insulin-like growth factor, and silase levels, and proteomic profiling. And now these are basically academic things. They are not even available in India, maybe some of them. But for academics, one should know all these things. Then other tests that may be used to diagnose early onset of neonatal sepsis up till we are in the mother. Now, if we want to take out the baby to be whether the baby is infected or not, then one should do serum interleukin 6 or any other cytokines levels like 16 and 10, procalcitonin levels, or serum amyloid A measurement. If they are being raised, then the chances are that the baby is also infected and should be taken care of. Now, the imaging studies, as far as the diagnosis is concerned, the fetus is viable, then vaginal ultrasonography to identify with the women with short cervix, and a shortened canal is associated with the high risk of preterm delivery. And preterm delivery predisposes the women or a mother to chorioamnionitis. Ultrasonography may also be useful to ascertain the fetal well-being by utilizing the biophysical profile. So this is a chart which can tell what are the things that can be positive in chorioamnionitis. Now, if we do the blood, the culture is positive. The WBC count more than 15,000 per cells per cubic millimeter. Then the C-reactive protein, the level should be more than 25.5 microgram per ml. The amniotic fluid via transabdominal and amniocentesis, the culture should be positive. The gram staining should be done, and it should be positive for the bacteria. The interleukin 6 level should be more than 7.9 nanogram per ml. The glucose should be less than 15 milligram per deciliter because it is being utilized by the bacteria. The histological examination of placenta will tell the neutrophil inflation, and umbilical cord also will tell the inflammation in the form of neutrophil there. Now, coming on to the management, the management is divided into as obstetric management and general management. The obstetric management is basically, management is basically the broad spectrum of antibiotics, right? Then the prompt delivery is likely to reduce the maternal and fetal morbidity. So then what are the antibiotics that can be taken? The standard regime is ampicillin with gentamicin. And if patient undergoes cesarean delivery, so anaerobic coverage should also be given in the form of clindamycin and azithromycin. If the if the mother is having a temperature, then acetaminophen should be given. So because the fever itself has got a deleterious effect on the fetal heart. Now this is a table which says what are the combination which can be used. It can be, most commonly used is ceftriaxone with metronidazole and clarithromycin. The second one which can be taken can be used is ampicillin, sulbactam, and azithromycin. With the long list of antibiotic combination which have, it is not a single antibiotic which should be given. It should always be a combination of antibiotics that should be given. Now, coming on to the how the delivery is to be taken care of, the basic principle is that the baby is removed from infection and the mother is removed of the infection. So therefore, delivery, if the patient is in labor, should be expedited. And most of the time with infection, chorioamnionitis, there is a dysfunctional uterine contractions are there. And therefore, the oxytocin augmentation should be done in these patients. With preterm patients, an indication to induction of labor and management of complexes. The management definitely is very, very complex because it is dependent on a number of factors like the gestational age and the clinical scenario that is there. And during labor, the continuous fetal monitoring should be done. The route of delivery should be ideally vaginal. It should be preferred. But it depends upon the obstetric indication, right? So it has to be, it should be done either vaginally or abdominally. The postnatal care that has to be taken care of these patients are usually routine care along with the monitoring of the wound infection, and then which typically resolve with the resolution is occurring. The outcome of the chorioamnionitis is there is a twofold increase in the abnormal progression of labor because the infection does not allow the uterus to contract properly, and there are increased chances of cesarean section with postpartum hemorrhage, and poor cervical dilatation and placental abruption can take place in this condition. The surgical complication after cesarean section are include endometritis, pelvic abscess, wound infection, thromboembolism, and bacteremia. Now, classifying the complication that can occur in a mother is basically are the dysfunctional labor. Then operative delivery chances increase, which I've already said in the previous slide. PPH increases, maternal sepsis increases, then postpartum endometritis and adult respiratory distress syndrome. This should always be taken care of because most of the time this may be the presenting symptom. Neonatal complications that can occur with the chorioamnionitis are that they can be meningitis, intraventricular hemorrhage, pneumonia, bronchopulmonary dysplasia, cerebral palsy, sepsis, and most important ones, which are the brain, is being affected. Now, it may be premature birth is occurring, therefore there are more chances of respiratory distress syndrome because of the pulmonary maturity is not reached. The neurological abnormalities, they can be retinopathy of prematurity or necrotizing enterocolitis, and even we may lose the baby. So differential diagnosis is basically off fever. It is urinary tract infection, upper respiratory tract infection, acute appendicitis in the mother, epidural associated fever, and placental abruption. These are to be excluded out because fever. This is a diagnosis of exclusion. So with fever, we have to take care of all the infection which can cause fever. Now, it is not only the mother, the baby should also be taken care of. And the CDC and the Committee on Fetus and Newborn is that full sepsis evaluation and initiation of antimicrobial therapy should be done. So when we start, it is basically the risk factor with chorioamnionitis, or maybe PROM may be present, then it may be more than 18 hours, or it may be intraamniotic parameters which may be not adequate. Now if this is a scenario, then we should subject the patient to diagnostic tests in the form of culture, WBC count and differential count, CRP levels, and should be done in the neonate at the age of 6 hours and 12 hours. then antibiotics should be broader spectrum, should be continued. And if the blood culture is negative, the initial infant remains well and lab data is normal, then one can discontinue the antibiotic. But if the lab data is abnormal, but the baby and the is normal and the blood culture is negative, then the antibiotic should be continued, and the during delivery and labor, and the baby should also be given. But if the blood culture becomes positive, then the antibiotic should be continued with lumbar puncture also done, because these babies are more likely to develop the meningitis. So this is, I think I finish off with my lecture, and I think I'm in time. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you so much. Can I comment now?
Sure.
Yes, ma'am.
Oh, ma'am, your lecture is so wonderful. So extensively, you covered the topic so beautifully. I was just thinking that my teacher is again teaching me. So, the chorioamnionitis, as you stated, the new terminology used as intraamniotic infections, and it is polymicrobial in nature. And this infection is controlled by host defense mechanism. So it is very, very important for all of us obstetricians during antenatal examination to diagnose the risk factors and means work accordingly so that amnionitis should not develop. But if it will develop, as Madam told us everything in detail, that how to deal with such patient so that we can minimize the complications. So, ma'am, thank you so much for excellent lecture. Excellent.
Thank you, sir.
Sangeeta, ma'am, your.
Thanks, Dr. Manju. It was a very in detail discuss about the chorioamnionitis. Now the question arises, why are we discussing chorioamnionitis with prematurity? So what exactly is in our mind that we are combining these two topics together? So because first we all know that it is the major cause of preterm or PPROM. So that's why we have to prevent and take all the measures to take care of chorioamnionitis so that we can prevent or at least delay preterm labor.
Yes.
Secondly, once chorioamnionitis is there, the behavior of the preterm child which is born is more deteriorating as compared to the cause of a prematurity by any other factor. So once the infection is there, the morbidity and mortality of the newborn is more as compared to other causes. Thirdly, there is some change in our management of preterm labor when the cause is chorioamnionitis. That means we don't prefer tocolysis. We say that tocolysis should not be there. We want to give early antibiotics and expedite the delivery and to have a second look on the decision of delivery, because we will prefer more of a vaginal delivery. Of course, obstetric causes are there, but we have in the back of mind that the cause here is that it is associated with chorioamnionitis, so we have to take care, keeping in mind the infection. And thirdly, role of steroids when we discuss in case of prematurity and chorioamnionitis together, we have to give importance to the severity of the infection also. We have to keep in mind that there is so much infection in the mother. So are we justified to give in the corticosteroids for prevention of for escalation of lung maturity? So I think so many points, many a times we are not finding the cause of preterm labor, but when the placenta is examined histopathologically, we find that there is some clinical infection was there or chorioamnionitis of there. Then again, as I said, that the newborn deteriorates fast. So it is, I think, basically it gives us the guideline to keep it in mind to prevent the infection in antenatal period so that chorioamnionitis is not there. So we have to take, and also we have to take early detection of infection, bacterial vaginosis, etc., so that they are treated properly and the preterm labor can be prevented. So I think these were the points that why we are discussing these two things together, is I just wanted to tell.
Thank you.
Thank you, ma'am, for your inputs. And Sudha, ma'am, can you please conclude the session?
Thank you so much, Dr. Manju, for that, excellent and, very informative talk. It was all evidence-based. It was a kind of wonderful, revision of the subject and very well summed up by Dr. Jaya and Dr. Sangeeta. True, we all know that it's a major cause of preterm birth and also linked to, long-term infant health issues. But we still, deal with diagnostic challenges. There is a still need for novel, minimally invasive tests to detect the subclinical inflammation. And I think in day-to-day practice, we all have been dealing with it. But I still remember, the postpartum hemorrhage, which happens following, chorioamnionitis if, not treated properly. So we all have to take, these things into consideration while we are dealing with these kind of patients. So thank you so very much.
Thank you.
Dr. Shikha? Thank you, Dr. Shikha, for convening this session. Thank you, Manju Verma ma'am. Thank you, respected chairpersons, Dr. Jaya, Sangeeta ma'am, and Dr. Sudha ma'am. Now we quickly move on to the second session. And for this session, I invite Dr. Mamta from BHU to conduct this session. Dr. Mamta, over to you.
Yes. Thank you, ma'am. Can you hear me, ma'am?
Yes, we can.
So, a very warm good evening to all the respected faculties present here. I'm Dr. Mamta from BHO, Ops and Gynae Department. And after the wonderful lecture of Dr. Manju Verma, ma'am, she is my UG time teacher. And Dr. Hema Jashobna ma'am is my PG time teacher. So two of my teachers are present here. My special thanks and my pranam to both of you, ma'am. So now we are moving to the second session, that is long-term implication and complication of the prematurity. For this, I would like to invite our respected chairperson. So our first chairperson, Dr. Sharda Jain, ma'am, it's my proud privilege to invite you, madam. We all know that madam is teacher of teachers, and she is director of Life Care Center and Life Care IVF, founder and secretary general of Delhi Gynecological Forum, founder of NIGF.
Madam, enough for me.
मैम आपके लिए मैं बस वर्ड्स नहीं है मैं क्या बोलूं देयर इज लॉन्ग लिस्ट ऑफ योर अचीवमेंट्स welcome ma'am welcome in second now I would like to invite our second chairperson Dr. Mitra Saxena ma'am. She is currently the vice president Foxy elect 2027 governor council member of ICOG 26 and 27. Madam has so many publication of Foxy, organized many conferences, many awards to ma'am, and area of interest is high risk obstetrics, ultrasound, endoscopy, infertility. And madam, I am big fan of your Tuesday classes with teachers. That is very wonderful lectures in that classes. So welcome, ma'am. And our next chairperson is Dr. Chanchal. Madam is currently Director of Fetal Medicine, Academic Co-Director of FNB MFM program, and Madhukar Rainbow Children's Hospital and Birthright by Rainbow Hospitals. And Madam is actively involved in so many academic activities related to Foxy, accredited ultrasound trainer at the current center. Madam has more than 60 publications in all the peer-reviewed journal. Foxy Rajat Ray, Fetal Medicine, and first second runner of award. She is the editorial board Journal of Fetal Medicine, BMC Pregnancy and Childbirth, Society of Fetal Medicine, Central Executive Committee member, and current member and past chairperson of FOXY and AOGD Fetal Medicine and Genetics Committee 25-20. Welcome, madam. So now I request our chairperson to invite our very eminent speaker, Dr. Sadhna Gupta, ma'am.
I would request Sharda ma'am to introduce Sadhna Gupta.
Oh, no, ma'am. Please.
No, I'm not going to go by all the things which are there, but I will say that, I appreciate and love Dr. Sadhna, and I find, the heights which she has reached is uncomparable. And one thing is, I'm glad that she is very fond of uh, maternal care during pregnancy, as well as her focus always remains on maternal mortality and to save the babies. So today she's going to talk on a very, very important topic, and that is prematurity. And I feel, she is going to do justice about it. And I think a lot of responsibilities are there on we gynecologists about prematurity prevention. And I think we will make a comment after her presentation. I have a wonderful association with her in the last 3 years when she was founder chairperson or founder president of NIGF. I think she has a long career ahead of us, and she will definitely do a great job wherever she is. So over to you, Dr. Sadhna, to talk about long time implication and complications of prematurity. And I think those things are very, very important for every gynecologist to know.
Thank you. Am I audible? Am I audible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
तो मेरा सादर नमन हमारे बहुत आदरणीय गुरुजन डॉक्टर शारदा जैन, डॉक्टर मंजू वर्मा, एंड ऑल डियर कोलीग्स, डॉक्टर रागिनी अग्रवाल. We welcome our president NIGF, Dr. Ragini Agrawal, Dr. Sudha Sharma, who is Secretary General, and all the office bearers. So actually, Amrita has given me a very different topic, that is the long-term implication of the preterm birth. So it is actually a holistic approach and not the obstetrician approach which we'll be sharing, but the facts are quite alarming, and we have to be aware about it, and it's a very different thing which I'm going to share. So my screen is
full screen, madam. Madam, make it full screen.
Yes, हो गया मैम.
So it will be of interest, and it may change our like a vision for the holistic health of the society. So that has been the great association, being founder president of NIGF, and all good memories. And we look forward to great future of North India Gynae Forum. Under the new executive, and Dr. Ragini Agrawal as president, Dr. Sharda Jain always as a guiding light, and Dr. Manju Verma as a dean. So children are the anchors that hold a mother to life, and it is more valid in the South Asia, where childbearing and rearing is given immense socio-cultural religious importance. But yet at the same time, right in South Asia, right in India, more so in North India, we need to do most and bridge huge gaps to make the reason really truly child and mother loving and caring, what Dr. Sharda Jain was actually talking about, that we need to bridge huge gaps at every step. So why this month is the 17th November is the World Prematurity Day, and this is very important statistics which we need to again very sensitively say that around 13 to 15 million babies are born preterm before 37 weeks of gestation. It is the leading cause of death under children under 5 years of age, up to 40% of under 5 fatalities. And what I am going to talk today is the preterm birth is associated with long-term physical, neurodevelopmental, and socio-economic effect in great number. So we have to break many nexus, and whenever we take decision of preterm birth, because of many reasons, technology, sometimes it is good, we have to be very
sensitive about it, and India is the biggest contributor to world prematurity burden. India followed by Pakistan and then the Africa. So this is something our problem, and this is again important fact that the data from the preterm birth 94% are from high income countries, and it is not from those countries who contribute to the preterm birth. So this is very important that we have to prioritize our all programmatic investigation. So preterm birth is not only the major contributor to neonatal morbidity and mortality, it is also accounting for increasing number of intergenerational non-communicable disease and a loss of millions of the disability adjusted life years. So this is the thing when the India and South Asia is struggling with the huge number of the non-communicable disease. Obesity, India is the biggest market becoming for the anti-obesity drug. The prematurity contribution can be also in a big way. So we have to follow these preterm newborn for all categories, and we will make a full circle कि जब हम newborn को preterm newborn को एक pediatrician को देते हैं और वो बच्चा फिर से हमारे पास आता है, so how we can a little bit take a different approach in our obstetrical practice, because we need lifetime approach in healthcare system. So there are mammoth challenges, and let's see and what can be the long-term impact of the preterm birth. So third trimester is a period of rapid organ growth and the maturation. And premature infants are born before major organ development is complete. And despite improvement in short-term survival preterm, every NIC unit, every like a academic session, we are proud कि हमने 700 ग्राम के बच्चे को बचाया, 800 ग्राम के बच्चे को बचाया, 1.5 ग्राम के. But actually that short-term survival preterm death, they can have the lifelong health consequences, which is by the concept that developmental programming or the Baker's hypothesis. So who survive preterm birth, they struggle with multitudes of disabilities because of improper programming of various tissues and organ systems, which contribute to adult onset disease at very early stage of their lives. So what we say nowadays, we are concerned कि 40 साल का the like 30-35 years people are in gym and they get the cardiac arrest or they die suddenly. So this is something that they get the adult onset disease at very early stage of their lives, and these all preterm babies can have the adverse effect related to organ which fail to achieve optimal development, to undergoing more rapid decline in their elder years. So this is something a very new and a panoramic insight into the future of the preterm birth. Very preterm infant born after hypertensive disorder of pregnancy or after fetal growth restriction have increased risk of late onset sepsis compared to born after spontaneous preterm labor. So what in my clinical practice, I think we will like to share this. I say that the preterm birth, which is born after leaking, they thrive better than the fetal growth restriction or the patient with the severe preeclampsia. So this is something which like obstetrician observation is also the same, and the late onset sepsis risk differ according to cause of preterm birth. With a brilliant lecture by the Dr. Manju Verma, that chorioamnitis, then what is the chorioamnitis? It is HDP, the immediate neonatal period can be very threatening due to the sepsis. So whenever we hand over the child to the pediatrician, first of all, this is in cesarean section, in vaginal delivery, we have to communicate that what the mother has gone into the antenatal period. If it is a preterm baby, why we are delivering? It is eclampsia, it is a multiple factor, it is GDM, or it is the fetal growth restriction, or it was something fetal infection which we were suspecting. So this is one very important day-to-day clinical practice, that if we communicate with the NICU team and with our neonatologist team better, they also can manage better, and they will provide the long-term and the short-term management in that way. Retinopathy of prematurity, madam has also touched. This is very, very important thing, because one of the most preventable cause of very sad complication, that is retinopathy of prematurity. it occurs in preterm and low birth when because of the abnormal blood vessels and scar tissue grow over retina. The incidence of retinopathy of prematurity is increasing because again we are able to survive more preterm and extreme preterm babies. And a very important point of warning that the unrestricted 100% and the excessive use of supplemental oxygen is one of the most important factor contributing to retinopathy of prematurity. Other modifiable risk factor for prevention of retinopathy of prematurity are infection prevention, poor weight gain, and the blood transfusion. So it is a obstetrician care also which actually adds to prevention of these things. We have to be very much aware. Even if our pediatrician forget, we have to tell to our families that get the all examination done for the retinopathy so that it is pass fail. Then the follow up is important and the treatment is available, and laser treatment is gold standard, and the cryotherapy. So the second point, that is the immediate thing which is related immediately to obstetrician area, like we are together at some point of time up to 1 month, up to 2 months. After that, we have to look for the other things, that is the increased risk of cardiovascular, metabolic, and kidney disease that suggests that these population, like preterm babies, should be monitored and counseled on healthy lifestyle. So let's say etiology of preterm cardiovascular disease. So this is important that preterm, but I wish to exaggerate one point, that we know what are the high risk factor for the cardiovascular disease. It is diabetes, it is smoking, it is overweight, it is diet. But in preterm birth, the cardiovascular disease risk is driven by structural change incurred at birth. So even they don't have these risk factors, these preterm birth babies, when they grow adult, they have more liability to have the cardiovascular disease because it is a permanently reduced dimension of heart and blood vessels, especially great vessels, compared to their term-born cohort. So these structural change take a backseat to functional and clinical complication within neonatal period. So we don't have more thing in the neonatal period, but when they become adolescent, their functional decompensation can be observed and they can have the cardiovascular disease at a very early and the young age. They are more associated preterm birth with the heart failure, and extreme preterm had 17-fold increased risk of heart failure compared to near term or very preterm. Hypertension, these babies when they go like in the adolescent age, they have the higher blood pressure, and any 2 millimeter Hg reduction, mercury blood pressure reduction in 6% reduction in risk of coronary disease. So preterm birth produce permanent structural changes to the heart and vasculature, and we have to say to them, their parent, कि आप इसका ध्यान रखिएगा शुरू से ही, so they don't get obese and they have to have the lifestyle modification right from the childhood. One point more, when the preterm birth are there, in sometime we get confused, echo कराते हैं लोग. So when the preterm baby is born, there are many physiological changes which take time to settle within 6 months. So sometimes over anxiety to parents, and that I will also cover. Now coming to pulmonary system, in first week of life, the preterm babies are more likely to develop bronchopulmonary dysplasia and the pulmonary hypertension, and in later life, 4-fold risk of asthma and higher risk of wheezing disorder. So they fail to reach the optimal peak lung function, and they can have especially the pulmonary hypertension and the 4-fold risk of asthma. Nervous system issues are a big way. Globally, there are more mental health problems. There are so many things. Autism, which we actually don't know why, which are causing autism, which factors are causing autism. And the obstetrician face a lot of medical legal issues due to that because it was birth asphyxia. But 95% of the autism is not related to birth asphyxia, and premature birth is also associated with higher risk of cerebral palsy, cognitive disability, and the seizure disorder. Subsequent hypoxia, the periventral leukomalacia alter the formation of prefrontal cortex and neural networks, which lead to the behavioral system. So there can be higher incidence of autism, mood disorder, attention deficit, very, very rampant in today's children. If you observe the children in party or in something, but risk is 4 times when the baby is born preterm, and even babies born at 36 to 38 weeks. So in practically, we take 36, 37 very safe for delivery, but actually even before 48, like 40 weeks, 38, the late preterm maturity also, the babies have the higher risk of developing in attention and hyperactivity and the low intellectual disability. So this is something we have to be very, very cautious and sensitive about it, because these babies can have, due to neuroinflammation, neonatal brain injury, as well as sometimes genetic vulnerability, more risk of the adult psychiatric disorder as well. So potential psychosis, risk, deficit attention, social difficulties, motor impairment are more with the following preterm birth: greater social and cognitive impairment, social difficulties, and isolation, because they may be having something like about weight, about growth. And today the world apparently is very appears to be competitive because of 24 into 7 social media. Generation Gen is more hooked to the social media, and the social defeat that can cause a lot of issue related with the psychosis. So these are few studies they have been done. This is BMJ studies, which shows that the infant born less than 33 weeks of gestation is investigating. It is going on that what is happening. Renal disease are also more common. Preterm babies are more prone to have, because preterm babies have fewer nephrons at the abnormal glomeruli at the time of birth. And the second important thing is that in NICU, they can be exposed to the nephrotoxic medication, and the Swedish registry shows twice risk of chronic kidney disease in the adult who have born preterm. And if even in stage 1 or 2 kidney disease, they can have 25 to 100-fold higher risk of the cardiovascular event. So even a little higher staging of the kidney disease, it lead to the more risk of the cardiovascular event. And this still no professional body says that you cover screening for CKD in premature born adult, but few things are in thought process like cystatin and urine microalbumin that you go on doing, and let's say that we can have. Preterm birth, always they have the preterm or low birth, they are more fat in the neonatal period and they are more likely to be obese. But the second point is also important. In third trimester, there is a time when the subcutaneous fat is rapidly deposited. So the term babies born tend to be leaner and lower fat store, but the baby born preterm, they have more visceral fat distribution, they have more visceral fat collection, and they tend to have the more obesity. So with obesity, with cardiovascular, with all associated this mood and the psychological symptom, they are more likely to have the diabetes, more type 1, type 2. And why they are more tend to have the diabetes and the impaired glucose tolerance? Because of abnormal fat deposition, decreased beta cell formation, which typically occurs in third trimester, altered T cell response, and the metabolic disorder. Bone and dental problems are also more chance of hearing loss, more tooth caries, delayed tooth growth, more infection, and more visual problem. Breastfeeding quite in a big way can prevent them from these bone disorder, but this is important. So as a first generation of survivors of extreme preterm birth are now entering middle age, we as a healthcare person must be aware of disease burden they may carry. And this is something, the long-term survival of preterm born adult is something very important. Implication with they can have the lesser life expectancy almost because of the telomere shortening and all the associated cardiovascular and the cerebral. And these are the data mostly from the development, because this type of data need a long follow-up, that they have the lower life expectancy who have been born preterm. It is a specific organ vulnerability, which can cause what I say telomere length shortening and DNA methylation, which lead to epigenetic modification that may appear later in life. So in IVF field also, we are talking now a lot about telomere shortening and the length for the healthy life expectancy, and this is the way of like a tomorrow. So what is our change in thought process that preterm birth should be regarded as chronic medical disorder, and conventional method for assessing preterm infant development as well as the precise growth monitoring, we have to be very particular, and they must have the different growth chart, and we have to have the individualized nutritional strategies concerning sex difference, male or female, birth weight, low birth weight, and the comorbidities like RDS, NEC, what the happened into the preterm period, neonatal period in that life. It is time to revisit that when we come, this is something you may find it very awkward, but this is the thing. जब हम किसी पेशेंट का हिस्ट्री लेते मे बी इंश्योरेंस समथिंग, हम उससे पूछे क्या आप प्रीटर्म बर्थ से, सो वन यू बॉर्न प्रीमेच्योर, व्हाट वाज योर गेस्टेशनल एज, व्हाट वाज योर बर्थ वेट, were you in mechanical ventilation, did you have any surgery, how long you stay in neonatal intensive care unit, what was the chronic disabilities, and what have the other complications. So length of stay in NICU and the ventilator requirement, that is something we have to be very, very pertinent. And of course, what was the gestational age. Good spatial screening will be useful. We don't know, but it is something from childhood we have to look into the weight, blood sugar level, and the cholesterol level, because the lifetime approach and make the parents sensitive. Because these babies may be the very pampered babies because they have survived a little very stormy childhood. So we have, as a doctor, we have to say one point about the parents of these preterm children. What agony, what mental stress they undergo, and parents says in few interview in very good paper that they want to be heard and trusted. So NICU care is also, as well as the adult ICU care. Now the whole world is thinking of revisit that. बहुत हमने technology कर लिया, बहुत isolation दिया. It is as bad for the adult to be alone into the like a ICU. It is as bad for the newborn to be alone into the NICU, and parents are away, and there is a lot of mental stress which we undergo in this thing, and we have to think for the revised approach for our NICU care and the long-term care of the preterm birth. So issue can be much more complex for the Indians and the South Asian, because NICU care, preterm birth care, rearing a preterm baby is very, very difficult, and we have to find the intervention to reduce social isolation, lessen financial burden, which is very, very crucial for our population, which we cater, improve home safety, and specialized insurance scheme. We have to prevent future prematurity, because a premature person who has been born as preterm, they can have again prematurity when they enter into the obstetrical or the reproductive life period. So fertility treatments is becoming more successful, more multiple birth, more obstetrical complication, and more babies are being preterm, but it can cause a cascade of the vicious cycle of the intergenerational disease, a very high cost for the family and health system for bearing. And we have to look into the environmental pollution and global warming also, which is very, very important cause of the prematurity. First and final statement: nature is mystic, powerful, and protective. So Lal Bahadur Shastri, Albert Einstein, Newton, and the athletes which like had gold medals into the sports, these are also born premature. And it is all about genetics and the epigenetics, that how they survived in those era when the NICU care was not that, where there was no much technological care. So all the friendly care, kangaroo mother care, simple loving care, and learning basic step of the child rearing, and the thing is very, very important. So we have to be always positive. So thank you, Amrita, for giving me this topic. It was something, a little bit journey where the world which we don't explore. But we have, as an obstetrician, we have to think twice or thrice when we deliver 36, 35, 34, 30. A little bit oligohydramnios, we are keeping a knee-jerk reaction. A little bit of growth, a little bit of CTG non-reassuring. So think that it is not only the immediate responsibility, but it is a long-term impact which prematurity can have. Long-term cardiovascular, neurocognitive, metabolic, pulmonary, renal problem, and we as a healthcare system need to be very sensitive and respond to parental pressure also in the NICU. So thank you very much. Beautiful minds inspire others. So we have all inspiring mind today. And congratulate Amrita for organizing first program of UPNIGF with all wonderful minds today. Thank you very much.
Thank you.
I think Dr. Sadhna, it had been absolutely wonderful. And it's a new area. In fact, people less talked about area. So you very nicely summarized preterm birth is not that end of that particular pregnancy. It's the beginning of lifelong health journey. Very beautifully you said, what is the reality in Bharat and Southeast Asia and Africa, and what is a global total implications. Uh, we see that, every preterm birth has a ripple effect. You can see immediately the medical, the emotional, the social, and an economic aspect of it. You touch very well. I find, delivery process में इतनी परेशानी नहीं है, but निक्को में बच्चे को बचाने में they really spend a lot of money. Mothers face higher recurrence. I was in the knowledge that it makes about 2 to 3 times recurrence is there, but you said the recurrence she faces in the next pregnancy is 4 times higher. They face postpartum depression because the baby is away in the NICU care, and the complex pregnancies are there in future. I mean, I was just reviewing it. More placenta previa, more placenta accreta, all that kind of problems are there. The babies struggle with, you said, respiratory problems, whole lot of there, and 4 times the asthma problem. I mean, that is also very, very interesting. Neurodevelopment problems are far too many. And as far as the retinopathy of the prematurity is concerned, and now we know not only it happens in preterm babies, but it is 100% oxygen which is the culprit. And now it has been the pediatrician neonatologists handfold and say that please do not give 100% oxygen. Room temperature is what is required. You also mentioned about, the Baker's theory. You highlighted that, whatever you find at this particular time, it presents as in the form of a Baker's theory, which later on is opens a Pandora box of non-communicable diseases. So I think, these patients not only be cared during pregnancy and the neonatal period, but I think a long-term follow-up of these patients are required. Prematurity is the leading cause of 40 to 50% of the neonatal deaths, and I think it has to be plugged. You can find that, there are few states, including Delhi, where the neonatal death rate is 4, but when you want to know Kerala, it is 1. You want to know Fernandez Hospital, it is 1. 10,000 deliveries. So I find, one has to really look for this thing. They are silent contributor to adult problem of hypertension, diabetes, poor learning. Families bear very heavy financial and emotional burden, Madam just now highlighted. So the call for gynecologists is identify and manage high risk pregnancies. And the time has come that proactively you must screen patients during the mid trimester for a short cervix and do this. You must counsel these people for inter-pregnancy spacing as well as a long-term follow-up. And what the madam just now touched about it, all those personalities which have survived in spite of preterm deliveries is that promote kangaroo mother health care. Breastfeeding especially must be encouraged in such patients. This particular baby can definitely thrive after this. And NICU linkages also, we have to see to it that we have those kind of pediatricians available which also believe that jitna bhi kam rakhenge NICU mein utna zyada acha hai. In fact, I know of a center which is Amrita Center in Faridabad, biggest hospital in Asia, they have the highest survival, and they say that we hardly put our patient on ventilators. We hardly put our patients on ventilators. So something need to be learned about it. And I think, this topic of long-term implication and complication of preterm delivery, all gynecologists must know about it and work proactively on this particular aspect. So thank you very much, Dr. Sadhna, highlighting the very, very important aspect of long-term implications. Thank you very much.
Thank
Yes.
you, ma'am. Yeah. Thank you, Dr. Sadhna, for presenting that topic beautifully. And as Dr. Sharda has summarized the talk and given us the direction that in which way should the obstetricians be working. So what I would like to add to that is that as obstetrician and as fetal medicine specialists, the two main contributors to prematurity, one is iatrogenic preterm delivery, which is mainly because of preeclampsia and fetal growth restriction. So as fetal medicine specialists, where we can help, and as obstetricians, we can screen women at the appropriate time for preeclampsia, triage them into high risk and low risk, start low dose aspirin in the correct dose at the correct time. And once fetal growth restriction is diagnosed, try to prolong the in utero stay as much as possible in accordance with the truffle trial. So for early onset fetal growth restriction, we all know that every day gain in utero prior to 34 weeks will improve survival by 2 to 3% and result in a better. The biggest message that the truffle gave us was long-term neurodevelopmental outcome in early onset FGR. And their cerebral palsy rates was just 1%, which was where the mean gestational age at delivery was 29 weeks and the birth weight was 1.2 kg. So those kind of long-term neurodevelopmental outcomes are achievable when we apply those criteria in deciding whom to deliver when. As far as spontaneous preterm delivery is concerned, I think we are still not being able to do much about it. However, there is evidence that if we do one mid-trimester cervical screening in women between 16 to 24 weeks and take the cutoff as 25 and give vaginal maximized progesterone in the correct dose till 34 weeks, we will be able to reduce the rate of preterm birth before 34 weeks by almost 50%. So I think these are the two areas where we can make a difference and we should try and make a difference. Thank you very much.
Thank you, ma'am. Thank you, Sadhna ma'am, for a great talk. Thank you, Sharda ma'am and Dr. Chanchal for your wonderful inputs. I think Mitra ma'am has not joined. And thank you.
Father is not well.
Okay. And thank you, Dr. Mamta, for convening the session. I really love your output. Your kurta is too good. So we have with us Dr. Apala, who is the treasurer, NIGF UP, and she would deliver the word of thanks. Over to you, Apala, please.
Thank you, Amrita ma'am, and a very warm good evening to respected seniors and learned colleagues. And it is indeed my proud privilege and honor to propose the vote of thanks on this auspicious occasion of the very first webinar of the UP chapter of NIGF. And at the outset, I express my naman to our Honorable Chief Patron, NIGF, Dr. Sharda Jain ma'am, for setting the magnanimous footsteps for each one of us to follow. Dr. Ragini Agarwal ma'am, a dynamic president, NIGF, and Dr. Sudha Sharma ma'am, a vibrant Secretary General, NIGF, for being the guiding force that radiates the source of energy within us. My utmost gratitude to Dr. Hema Shobane ma'am, President UP State NIGF, Dr. Bharti Maheshwari ma'am, Vice President, Dr. Amrita Jaipuriar ma'am, Secretary UP State NIGF, for being the strong thread that weaves us all together and inspires us to work harder. My heartfelt thank you to our esteemed speaker, sites in Koreanitis, and it indeed cleared so many of our doubts today. and Dr. Sadhana Gupta ma'am for a very enlightening talk today and always, and for always giving new dimensions to the dissemination of academic knowledge. My earnest gratitude to our esteemed chairpersons, Dr. Sharda Jain ma'am, Dr. Jaya Chaturvedi ma'am, Dr. Sudha Sharma ma'am, Dr. Sangeeta Gupta ma'am, and Dr. Chanchal ma'am for their crisp and precious quick bite takeaways that etched the key messages into our memories. I thank Shield Connect for managing the necessary logistics. And finally, a big thank you to all the delegates for making the time to be with us today and making the event magical. Thank you, one and all, for the memorable togetherness. Long live NIGF. Thank you, ma'am.
Long live NIGF. Thank you. Thank you, ma'am.
Thank you.
And
Thank
such,
you all.
such
Thank
a
you.
wonderful thanks message.
Yes.
Very nice.
Thanks a lot, ma'am.
Thank you so
Thank
much,
you.
ma'am.
Thank